that I should do. Always tell the story first because everyone likes story. This story should be true story, it should be personal story about me. It should be funny, interesting, but for me it's kind of scary. Because I'm an assistant professor and I'm quite tall, so I do for many years been teaching my students and gave them lectures, and this becomes quite stress-free for me. But every now and then, and now it's like maybe 2 or 3 times a year, I get some, let's say, invitation to give some special lectures. Let's call it special lecture like this one today. It's not for my students, it's for some other students, postgraduates, colleagues, residents. And those lectures are definitely not stress-free for me. But I kind of try to make them stress-free because those invitation goes like, well, we have this, would you like to come? Yes, you can talk on any topic you want to talk. So I usually now have 3, I would say, rather great prepared lectures, and I always do them over and over for years and years, always the same. And I believe that I'm quite good at those lectures, and I know when to pause, when to stop, when to make a joke, how will the audience react and everything. So I kind of try to make those not stress-free special lectures to be as stress-free as they can be. But, of course, there is but. My previous special lecture was in mid-June, that was 2.5 months ago. And I was on the phone with the organizer, and it was like, welcome, okay, and I said, I would like to talk about this. And she goes like, oh no, that's boring. What? I would like you to talk about this and this and this. And I was like, but I don't have that kind of lecture prepared already. And then I was like, I was very quick thinker at the time, and I said, yes, and can I connect this with, of course, with something that I already have prepared? Oh, that will be perfect, yes, okay, so half of the lecture I have to prepare from the point 0, and half of the lecture I already have. And now, today, well, you know Stipe, you know him for now 10 days, maybe some of you longer. And now I have to ask you a rhetorical question. Rhetorical question meaning that you don't have to answer because everybody knows the answer. How do you think he invited me to give this lecture? Was it like, oh, come on, you can speak whatever you want, it will be fun, we will drink coffee and everything will be perfect, blah, blah, blah. Or was it, I want you to talk about this, and this. You should cover this, and this topic and show this, and these cases. So, rhetorical question. He doesn't listen to me at all.
It was on time.
It was on time, yes. It was on time, okay. But the funny thing is that that previous moderator that wanted me to give another lecture, can you imagine that she is also an orthodontist? And so that lecture was about ortho patient. So I again kind of make it half stress-free because second part of the lecture will be that lecture that I already have prepared. So it's kind of, I think, stress-free. But I'm getting a little scared, as I said before, because I'm worried about the future of my special lectures. So is it always going to be like this all over again, start from point 0? That's the story. I don't know whether you find it interesting or not. I find it, as I said, a little bit scary. The second thing I was thinking about is who will be my audience. Who are the people that I'm talking to? And I understand that you're all young orthodontics or residents or people that are interested in orthodontics. And I must say for myself that I am rather ashamed of how little of orthodontics I know. And then I was thinking, what's the purpose of me telling you anything? Because I have to prepare the lecture for my audience, not for me, not for Stipe or for anyone else. And then I thought that I could maybe give you some other perspective on some topics and some problems that you are facing or could face in the future of your everyday work, and hope that it will be interesting and that it will be beneficial for you. So
it worked. I checked. Try on off on maybe again.
Nešto se skroz zablokiralo, jer neće mi ovako. Okay, so the topic is alveolar envelope, orthodontic treatment and gingival recession. So, as I mentioned before, I will give you this presentation. So
We need to have a photo of you with this
okay.
for our Facebook site.
Now, how I don't know which profile.
Who is taking?
All kinds of
Yeah. Maybe
Okay.
maybe
so,
you could go a little bit forward. That would be the perfect perspective. And Tihana is the official photographer.
And smile.
And smile. Yeah. Okay.
So as I mentioned, we got two parts of the lecture. The first one is ortho treatment and gingival recession. It is theoretical part, and I don't know whether you will find it interesting or boring. The second part, I would say that I will present you some inspiring clinical cases that you may find interesting. Then questions and answers. Of course, Stipe, please help with this ortho part of your questions, but definitely feel free to ask any questions before. We don't have to wait. You don't have to write it down, and then at the end that we discuss, you can interrupt me and make a comment or anything you like. And then we will try to make some conclusions and take home messages. So we start with the theory. There are lots of good and bad things that connects ortho and perio. And I will start with these maybe bad ones, some complications of your treatment on periodontal tissue. And these are listed: gingivitis, periodontitis, gingival recession, gingival hypertrophy, alveolar bone loss, adhesions, fenestration, and dark triangles. With these aberrations, you know what are we going to talk about more. Of course, gingival recession, alveolar bone adhesions, and fenestration. I read a lot of papers, lots of things in the past 3 weeks when I was preparing this lecture, and I was having trouble how to sort of organize everything and how to present it to you. And basic for my presentation is this one article, which covers 7 topics. It is actually one meeting that was held in 2013. And they published it, and then this is the outline for my presentation. Those 7 topics are this one: etiology of recession, then some studies with animals, clinical studies, aspect of this bone envelope, what does it mean, clinical matter, post-orthodontic treatment period, and the treatment of gingival recession. So we start with the etiology. There are lots of talk about etiology, and I, as a periodontologist, think about it in different way than maybe you, as orthodontics, think about it. But what I find quite interesting is that there are some factors that can be divided into predisposing factor, that is anatomical and morphological characteristic of a patient, and then we have some precipitating factors that are leading to acceleration of the defect. So these anatomical factors can be deficiency, thin buccal mucosa, crowding, aberrant frenulum, ectopic tooth eruption, gingival biotype, skeletal pattern, and tooth morphology. And those that can lead to acceleration of the defects are traumatic tooth brushing, piercing, traumatic overbite, age, smoking, parafunctional habits, and practice. this is combined from many articles and try to divide them into these two groups. Beside those factors, we have orthodontic treatment, and let's say what we are dealing with when we talk about gingival recession. This is that if we move the tooth outside of the alveolar bone, this is the main issue that we are talking here. You will see later. And what about this treatment in the etiology of gingival recession? Is it a risk factor or there is no association? And is it maybe a iatrogenic factor? We'll see that there is no definite answer. When we talk about etiology, we have to talk about bone dehiscency and bone fenestration. That bone dehiscency is that this top of the alveolar bone is not where it should be. It is just above semi-triangular junction, but it is further apically. And the fenestration is that we don't have bone here, and the root is actually exposed here. These are factors that definitely influence the occurrence of gingival recession, and of course that we will talk about, especially the deficiency, more later in the lecture. When we talk about the dehiscency and fenestration, we always have to think about the thickness of the alveolar bone. And nowadays we have modern CBCT, and then we can actually see how thick or thin the buccal or lingual bone is. This is the sagittal axial section on the middle third of the root. So basically at the middle of the root. And there are of course some areas, you know this better than me, that are very tricky, and that the bone is very thin or there is no bone at all. Canine, the mucomesial root of the first molar, and of course in the part of the mandible. That bone definitely defines the boundaries where you can move the tooth, because you know that you can move. There is no nothing good will happen if you move the tooth outside of the bone. And the other thing is that previous slide was at the level of the middle third of the roots, and if we look at the root apex, then we can talk about hyperdivergent patients with thick alveolar bone and the hyperdivergent patients with very thinner alveolar bone. We talk at the root apex. So, especially in the lower anterior region, sorry, that was too fast, here we have more restrictions. I mean, you have more restrictions when you try to move your teeth, and here you have less restrictions. What does it mean? It means that the tipping is better than bodily movement. If you imagine that this is your, how do I say, this is the crown, this is the root. So, of course, that if you go bodily movement, that you will go outside the bone. So, better is to tip those teeth, and of course, the rotation center should be at the level of the root apex. Why? Because there at the root apex you don't have the bone. But now imagine if this is your tooth, and then you try to tipping it like this. So this is your alveolar bone. You will very fast go outside. So I really don't have a clue, and I don't have idea how to move tooth like this. Really don't know. If you go bodily, no good. If you do rotation here, then you have problem here, and if you have rotation here, then you have a problem at the root apex. So I don't know where to move and how to move. And these are.
Do you see now our problem?
Yes.
Do you see it?
Yes. I will come to that later. I will come to that later when we talk about me, of course. These are your cases when this is especially big problem, protrusion. Then when you have this camouflage treatment of class 3, and then when you have a compensation, and when you have progenia that is treated surgically. I must say that I learned a lot in past.
You're using the terms just correctly, so I'm really impressed.
Okay, just now let's see what animal experimental studies told us. There are studies with a small number of animals, dogs and monkeys. They say that if you move the tooth outside of the cortical palate and then retaining them in this position, you will lose the bone and you will lose the soft tissue. But then with animals it is possible to move those teeth back, and what will happen then? You will gain up to 50% of the bone, but not soft tissue. So these are the results from animal studies. What about clinical studies? The term that is usually used is to use light and control orthodontic forces, but all those studies, we can say that they have weak methodology, short-term follow-up, and some other factors that cannot be compared one study to another. Especially is the topic that is of interest is the proclamation of incisors and the occurrence of gingival recession.
Sorry.
Yes.
What is the short-term follow-up? Like 5 years, up to 5 years?
Up to 5 years,
Up to
yes.
5 years.
We always like, when we talk about periodontology, we want 5+ years.
5+,
This is what we find like.
We also want that, but people simply don't want to see it.
Okay. I find one clinical study and I was said, oh, perfect. So this is risk factors, gingival recession, in different orthodontic treatment, and this is a very new article. They have 100 patients, 3 groups. One was extraction, one was that the inclination was more than 5 degrees, and one group was only arch expansion. And they divided their conclusions of those who are lowering the risk of gingival recession and those where there is a greater risk for gingival recession. So those factors, let's say good factors, are if we have more keratinized tissue before therapy and after ortho treatment, of course, if the width of mandibular symphysis is greater, and if the intercanine width post-treatment is bigger. On the other hand, greater risk is if we have greater arch depth and, of course, non-extraction treatment. This is what they found. The second
Once again, sorry.
Yes.
Sorry. Professor, maybe you can help us. What does it mean post-treatment intercanine with seen from the crown level? Or
Yeah, from the crown. It is usually measured from the tip to tip, but I'm not sure whether it refers just to mandible or also to maxilla post-treatment intercanine width.
So I have all
Okay,
here.
okay.
We will look later. This is, I would say, very well done investigation, because they did end-ortho cast models measuring CBCT and everything to find out all these parameters. The second study that I found, and I was very thrilled when I found this one, so this is a systematic review, very new, of lower incisor and gingival recession. So they find 1,007 titles, and then you know how these articles are done. So you just eliminate, 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 and eliminate. So they read 121 abstract, that eliminated, eliminate. Then they find 35 full texts that they did, and finally they find only 2 retrospective observational studies, and no meta-analysis could be done of these studies. And the conclusions, of course, I don't know about you, but I'm very frustrated. When I see this title, I expect very much information. And then when I read conclusions, and I say, are you kidding me? So this is word by word. No scientific evidence exists standing that proclamation of incisors following orthodontic treatment with fixed appliances applies increases the risk of gingival recession, and of course further prospective and randomized studies are needed to clarify to which extent propagation of incisors should be considered as a risk of periodontal health.
Wow, cool.
So, this is about some clinical studies that we have on this topic. And now, let's talk about this alveolar bone envelope. So, cortical bone definitely is the anatomical border of this envelope, and this is the limitation of your possibility to move the tooth, whether you do it bodily or typically. Of course, you can move to outside the bone, but then there will be some health of surrounding tissue will become affected, of course. When we talk about orthodontic expansion, there is a trend of non-extraction treatment in orthodontics. I think that you are very well aware of that, better than I am. And then, of course, gingival recession, attachment loss, and deficiency could become more frequently. You can see them as a result of your therapy. We can talk about transverse expansion in this lateral region and on sagittal in the frontal region. So, of course, we need to know the thickness and the height of the buccal alveolar bone. Studies, they use different materials and methods, clinical examination, CBCT, but they are predominantly done on young patients and on healthy patients. I mean, they don't have periodontitis or reduced periodontal tissues, so we cannot actually talk about those results. But they say that rapid maxillary expansion can be associated with the presence of deficiency and the reduction in buccal bone plane. And the thing is that the thinner the bone onset was, the greater these changes and the frequency of deficiency is greater. So the thinner bone in the beginning will lead to worse results in the end. Some studies find that 20% of single and 6% of multiple recession after treatment. Some studies find no effect. But what they concluded that the grown patients have more favorable and more predictable outcomes. So the patients that are still young. Light force appliances is something that is always there, that they say you should do like this, not this rapid movement. But when you do buccal tipping, you got a similar result and the effects as this rapid maxillary expansion. Of course, too short follow-up period, maybe just when the appliance is removed or short period after that. So these are the things about transverse expansion. And when we talk about sagittal, so when we talk about incisors, then of course we have the same problems, and we have the thing is that then we have attention to the free gingival margin, and then we have reduction of gingival tissue in both thickness and height. But we will talk in detail about this later, so just now to just have an information about this. Of course, we have some factors, again, what we talk, age and biotype, width, extent of proclination, presence of plaque or traumatic tooth brushing, and of course, however, correlation or association is not consistent through the literature. So we cannot have any conclusion on that. And now we come to the most, I would say, important part of the lecture. What does it all matter? What is it for your practice? And here are some recommendations for you. What you should try to do. First, you have to identify risk factors. We talked previously what are these. And then you have to know that some of your treatment options are not as good as some. No, it's wrong. For me, it's a wrong term to say that they are not good. They are good, but they increases the risk of gingival recession. So every arch expansion, proclination, rapid maxillary expansion in adults, then of course class 3 before surgery, and aligning topical transported. The thing is that these risk assessments should be done prior to start of your treatment, so that you should measure the baseline gingival recession, meaning before the treatment, considering patient's age, biotype, then what are you planning to do with what kind of orthotherapy you are planning to do, and of course how much bone around the tooth you actually have. There is also one acronym ABAF for the risk factor. A is for anatomy of the alveolar bone and the proximity of the root to the cortical plate. Then B is for biotype, E is for environment. That means oral hygiene habits, poor brushing, poor orthodontic treatment, not poor, but this that has a higher risk, and some active lingual retainers, and F is for functional matrix. Well, not everything is so dark and bad, because we have some benefits of orthodontic treatment on gingival recession. That can be better oral hygiene, crown alignment with the dental-alveolar envelope, removal of occlusal trauma, then root alignment with the bone, and for helpless tooth, then we can, with your orthodontic extraction, we can develop implant site. And when I was reading this, I was thinking, how would it be that that you don't make tooth movement according to your rules, but you try to do it according to maybe some perio rules, so that you don't think about when will this crown end, but to think when will the root end, and to position the root in the middle of the alveolar bone that you have. I don't know how close you put that.
Yeah, that's the problem. We would not have well aligned teeth,
Yes.
and that is something that the patient is
Not
wanting.
satisfied with
Yeah,
the course.
sometimes I also tried a lot of approaches. If the patient has a singular recession, is it the term singular?
Yes.
Singular recession, and if the periodontologist is asking me to torque the root of the incisor, lingual torque of the lower incisor, then the crown will not be aligned, and the patient came because of the crown, not because of the root.
Because of the root, of course. Yes, you know, that was just kind of kidding, joking, but sometimes I really think that if the root would be aligned properly, I don't care. I mean, it's our point of view, not the patient point of view. There are some treatment modalities to minimize the risk of gingival recession. These are some of them. Of course, maintaining good oral hygiene. Then eliminate potential piercing, smoking, traumatic toothbrushing. Avoid uncontrolled dental-alveolar expansion, and maintain arch form. And then try to modify your therapy to lower the risk. Modify anatomy whenever you can. Consider segment arch approach. Then create space and using it before using it, and using it wisely. You know what that means.
Yeah. Anchorage control.
Okay. Then, of course, avoid jingling, because it can definitely cause perio problems. Treat early in mixed dentition, and re-educate patients after the end of the treatment. And now I would like to go a little deep, and this is maybe for you the most boring part of the lecture, but for me is the most exciting. To tell you about the development of gingival recession, because we all, when the patient opens his mouth and we say, oh yes, you have here gingival recession, but what really happened before that recession is actually developed. So first of all, there was definitely before recession there was deficiency. Of course, we talk about it, and you know that when you very extremely thin bone and when you displace tooth outside of the bone, then you have deficiency. Another tip is to apply light and well-balanced force, but for the sets of the teeth rather than just to a single tooth. So to try to move all the teeth together, not just one teeth. Deficiency cannot be diagnosed by visual examination, and gingival recession is not immediately there, so we cannot see the problem. And the thing is that after the bone is gone, there is a good connection with of the soft tissue with the tooth, so that we don't even have the perio pocket here, and everything looks great. Before, when we taught our students,
so we have a camouflage.
Yes. Before when we teach our students, when we say, if we now do the operation of all of us, who knows what we will find? Nowadays we can say if we do CBCT, who knows what we will find? Maybe some of us really have the deficiencies, but we do not have gingival recession. The second thing we have to think about is periosteum, and that is the something that covers the bone from the outside, and it is consists of Sharpey's fibers, that is collagen fibers. We can talk about outer layer and the inner layer. Here are these collagen fibers. Center is of course for muscularization. Inner, that is near the bone, so there are all these bone cells. And now, when we have thin or non-existing bone, and that is when we have fenestrations and deficiencies, then the periosteum is still present here. So actually, if we think about molecular level, then it is very difficult to say, is it only periosteum, or is it really bone, or do we actually have, or we do not have deficiency or
and periosteum is not seen, is not visible on CBCT. We cannot diagnose whether there is some periosteum present.
And what happened when we have established gingival recession? So all of this, what I said previous, is something that is here before recession, but when the recession is here, then of course there is no bone, but there is no root cementum, because you cannot see the root cementum in the oral cavity because it immediately exfoliates. And periosteum, you don't see either periosteum because there is no bone, and the root surface is covered with the dentin, which is exposed to oral environment, so there are all the full of bacterial lipopolysaccharides that is it's covered with this. So this is gingival recession. And now I have a, well, it's not a picture, it's something that I've done, so we'll see later. So just to tell you, bear with me just this slide. Healing after the treatment is long epithelium, long junctional epithelium on previously exposed dentin, because not just the orthodontist, but the general practitioner and the periodontologist in the last century thought that we can regenerate the bone. We cannot. On that side, because that bone was very thin, and now it's gone, and now this is the dentin. And how can I put some bone here and cover it with anything and imagine that it will actually heal? So we cannot help you with the bone. That is something that you, when you ask your periodontist to do something about the recession, you have to know that we only think about soft tissue. We don't deal with the bone when we talk about gingival recession. There is no creation of new periodontal ligament and no outer bone plate. We are not a magician, we cannot do that. We can only do connective tissue attachment, so we only deal with the soft tissue. And now I wanted you to show you some picture of all of that I've been talking. And of course on Google you can find lots of nice pictures, but I deliberately decided not to do that. And I want you now to try to imagine all the stuff that we've been talking. Try to visualize it, each and every one for you, for yourself. I don't know how you can imagine tooth and everything, but let's try do it together. So we're talking about the tooth, bone, and the soft tissue. So you know that the root of the tooth is, okay, here we have a pulp, but we are not talking about that. So we have dentin, then it's covered with the cementum, and then we have periodontal ligament. This periodontal ligament is, so this is the tooth. So this periodontal ligament consists of these collagen fibers that is called Sharpea's fibers that are kind of connecting from this cementum to the next structure, and that is the bundle bone. Bundle bone is the first bone that is here with periodontal ligament, and this is how I imagine these fibers. I don't know how you, but they are definitely tightened from here to here, and this is like a knot. This is how I imagine it. It's not a knot, of course, but this is how this is connected. And the bundle bone is a part of alveolar bone, but it is connected with the perioligament. And now in implantology, when we talk about tooth extraction, then when we extract the tooth, this bundle bone is also gone because all this is moved away with the tooth. When we talk about alveolar bone, then we have trabecular bone, and here we have cortical bone. So these are all structures. Now, I don't know how you imagine all that, if you are still with me. And then, as I mentioned before, after that alveolar bone, we have periosteum with 3 layers. So these are these cells from the bone, vascularization, and here we have this out layer. Also, we got these collagen fibers that are connected perios with the connective tissue. Here we have epithelium, and this is our gingiva, this is our soft tissue. And now, imagine how, I don't know how to say about orthodontics. Now, I'm not going to say that you are stupid, because I'm also stupid when I'm doing something. Imagine now you have, and now you are moving. Whoa! Are you crazy? You are moving it here. Whoa! If you think on that level, I don't know how any of your patients ever survive. That's also for me the case. Imagine now I'm doing a flap surgery. I'm cutting somewhere, here, I'm destroying everything. So we are kind of very lucky that our patient can survive all the, let's say, bad things that we are doing here. That is the one thing that I wanted to tell you about with this. And the second thing is, we talk about very thin alveolar bone. First, when we have thin alveolar bone, then we don't have this part. We have cortical bone and we have a bundle bone. But sometimes we don't even have this cortical bone. Sometimes we only have this bundle bone. And sometimes we have deficiency. So we don't have the bone. But we have periosteum. But look how this is very similar. So this is kind of connecting here. And we can actually, we kind of do not need this part of, and everything can work okay. But when we have recession, we don't have soft tissue, we don't have periosteum, we don't have alveolar bone, we don't have ligament, we don't have cementum, we only have. So when I have to deal with the recession, I am not a magician. I cannot do all this. I can do only this. Poof, with this, somewhere here. Okay?
Yeah.
But
So just sticking.
just forget about the bone here. This is what I wanted to show you with this. Of course, I can find a better picture for this, but I really wanted just to say so that you can be aware of all these. And this is pure anatomical stuff. But when you think about it in that way, I think that I don't know. I'm not scared to do anything.
Yeah, yeah, yeah.
Hope not. Hope not. Okay. Post-orthodontic treatment period, of course, we want these long-term studies. Considering the change in the lower incisor inclination and rotation that we find studies didn't find statistically significant differences in correlation, but at the end of the treatment was found as the greatest predictor of occurring gingival recession. The older the patient is, the more recession we can expect. And if we look at those post-orthodontic treatments and control groups, of course, more recession are in those patients that were orthodontically treated. Treatment on gingival recession, I talk a lot about with Stipe, of course, is it before or after your treatment? So prior, we want to increase the soft tissue, mainly the thickness, not the height. The thickness is that we want to do prior to your treatment. Of course, ideally will be that you don't move the teeth when you have to move, where you have to move the teeth in those cases. Of course, oral hygiene, and then we can do some surgery to thickening the soft tissue, and of course reevaluate the need of some surgery after the treatment. So sometimes we do only after, sometimes we do only before, sometimes we do even before and after in some cases.
So the second part you are dealing with the height, and the first part was just the thickness.
Because we cannot be sure when you're done with the tooth movement where will actually the gingival margin be. So this is this first theoretical part, and I would like to end it with one case presentation, and Stipe will help me now with this. This is Mia. She was 14 when I first saw her, now she is 15, and now I'm sorry that I have to go to slides from Stipe. I didn't have time because I'm 2 days short for this. I was supposed to be on Friday, and on Friday everything will be in one presentation.
Although you were informed a year ago that you will have this lecture, and although I also sent you a message 3 months ago, and although, so, okay.
Such a great, such a host. So this is Mia, and she has some ortho problems, but she also had, you don't see it here maybe clearly, but on the bigger picture, she's having here fenestration. I mean, there is no soft tissue here. This is the bone, the root that is exposed here. So if we look at her gingival margin, everything is okay. This is not a recession, but here we don't have soft tissue. And she came to my office when she was 14. That was a year ago. And I look at this and I said, well, basically, see you later, alligator. Okay, we'll see each other definitely. We have to do something here, but now you are too young. And she was, of course, with her mother, and her mother was here, and they were talking about orthotherapy. Okay, we're here, Stipe. Okay, we'll discuss it. Surely we will do something. But now you are too young, and this is it. And then I, of course, forget about Mia. And then what happened is that her mother is a very good friend of one of my friends, and she called me and said, "Oh, you know Mia? I don't know, blah 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 blah." And so she was talking about that Stipe is also involved in her therapy, and said, "Okay, I have to first discuss the case with Stipe, and then we'll see what we have to do here." And then, of course, Stipe was not here; he was somewhere in Europe. And the mother was, "When can Mia come? Wait, I have to talk first with Stipe. I don't want to see Mia before I discuss everything with Stipe." So this is her picture, and this is something that is more of your interest. So Stipe, can you now just explain a little?
Okay, so she has a proclined lower incisors, not too much, but there is a tendency towards proclination. There's also a tendency towards proclination of the upper incisors, and the curve of Spee in lower arch pronounced. So, and she has crowding. In order to level her, we have to procline if we don't want to extract. If we want to extract, we also in the first phase will have proclination, and she doesn't have a bone, and we see that she doesn't have the bone because there is a fenestration.
So these are the level of the bone is 3-1 here, 4-1 here.
That we didn't saw. So the 4-1, there was no problems, not visible problems from the outside. But there is also problem on vestibular side, missing bone, cortical bone on 3-3.
And here on the lingual side.
But also some lingual sides that we didn't saw.
And here,
yeah.
Here is the mark. You cannot see how little is
cortical bone. There's just a little bit of cortical bone. We cannot move the tooth in the cortical bone.
Here is kind of good because we have the bone, but it's all cortical.
Cortical bone, so no movement available. Here is also better.
So this is that alveolar emerald. And now Stipe told me all about this and showed me those pictures, and I didn't know nothing about it, and I was like, okay, so you have a problem. But now I have to also deal with this problem because I was asked, because of my mother and my friend and blah, blah, blah. And then I said, okay, let's be practical from my point of view. She will decide to go on orthotherapy or no. So she got only two scenarios in my mind. And if she goes to orthotherapy, then Stipe, you would like that she has something here instead of not having anything. And Stipe said yes, of course. And if she decided not to go on orthotherapy, then it will be better that she has something here instead of having nothing. And we said yes, so I have to do the treatment. I was very scared when it was 4 months ago. Now I have pictures from last week to show you the success of the operation. Well, when we talk about the treatment of gingival recession, the lower jaw is the worst case. It is always very unpredictable and everything. And the thing that I was the most scared was her age. 15 years, I never done an operation in such a young patient, and I didn't know whether she can.
She's even younger. I think that she's 12 or 13. She's not 15.
She is. I saw it in the record. She is.
Because
yes,
I wrote here MS 12. So at the time when we took pictures, maybe, she was 12.
Maybe. Because I didn't know will she be able to do it mentally. Because I cannot, let's put a temporary filling and come tomorrow. So we have to do all the procedure, but she was very, very well prepared, I would say. And now this is the problem, and this is the margin. So I wanted to tell you that this we do not define as a recession, but to treat this, I have to deliberately make as a recession, and then this is the amount of the recession, because first thing I did, I cut this thing, so I created recession, and now I have to deal with it. So you see, actually baseline was quite big recession, and this is at the end. Now this is recession, and I try to, well, the photography is not accurate, but you can, I just put it down, so to show you that we did have some success. This green, let's say, is what we gain with the tissue. And now the funny thing is that the green is actually this part that before we didn't have the tissue. But she's only 15. I can do this procedure when she's 17, when she's 20, whenever. But I don't know when will you do your ortho. Who knows? Who knows? So this is actually one very tough case for when you think about orthodontics. We can do here several procedures, and we can deal with this, but with the soft tissue, not with the bone.
Because even if we as orthodontists try to make orthodontic treatment here with extractions, and if we were very successful, would be very successful in controlling the position of incisors. When we level the curve of SPI, when we try to pull the teeth back, we will have some tipping. So the roots will go out, and she doesn't have a bone. And we cannot move it also much more, let's say, distally, because there is a cortical plate there. There's no spongiosa. Where to go there? So that was a big concern for me, and I spoke, you weren't here, so I spoke with several times with parents, discussing, explaining that it would be wiser not to do anything here. Wiser. Because if we take the path or the trip, we will lose the bone, the tooth, the tissue. And if we want to maybe to torque just a little bit a root lingually, we will have lingual recession instead of vestibular. Which recession is better to cover with vestibular recession is better to treat, easier to treat with some grafts, because on the lingual side you have a tongue that is moving and it will go away. So it is better to have buccal recessions or labial recessions.
From a surgical point of view, how did you do the treatment? What did you do?
The treatment was, well, I was planning on making this presentation about the treatment, which is easier for me and maybe more spectacular for you. That wasn't the order.
Yeah, okay.
So you elevate the flap, and then you take the tissue from the palate, put it beneath, and then cover everything in a hypercorrection, in brief. So you
Coronarly, so you move it
wax,
coronarly.
because you want to cover it and you want to make it thicker. That's why you need the connective tissue and covering everything up. This is basically what is.
But
what
as
is
the things relapse in orthodontics, they also relapse in periodontology.
Yes. So the second part are some clinical cases, and this is, I would like to start with some maybe dogmas. In this is perio dogmas. What are the treatment goals? The treatment goals of periodontitis. We don't want to have inflamed, we don't want to have gingivitis. We don't want to have deep pockets. We do not want to have open furcations, absence of pain, and satisfactory aesthetic and function. These are our goals when we treat the patient. I think that maybe these are your goals when you treat the patients. You know that. Okay.
Yeah.
So with a, I don't, so you know. Okay. So we can walk. But and these cases are. This is not neither perio presentation, neither orthodontic presentation. This is like maybe, let's say, general practitioner presentation to show you what can be done. The first patient is Diana. She is quite old patient. When she came, this was her problem. And these are the pictures. So this was a perio problem and abscess, and then traumatic occlusion, and she said, I would like to do something about it. And then I was like, okay, I will extract this tooth, and then I will do the socket preservation. I will put everything and do lots of things, and then she can place an implant here and do the crown. And then I was
Two
saying,
crowns.
No, one.
Yeah.
One, but very big.
Yeah.
So, and she wanted to help me with that. Then I said, no. I will send her to the prosthodontics, and they will then do some bridge work or something like that. And then I was thinking, well, if that tooth came, can someone bring it back? This is actually Stipe took the photo. That was when we didn't have a computer, and this is my kind of treatment plan. So, and they said
8 years ago
with Spal. Now to extract the tooth and then put the bone and or ortho extraction and just do the ortho treatment, and this is her after. The thing that was done here is only upper arch because patient didn't have money for the full ortho treatment, and this is how it looks at the end. So this is the beginning and this is the end. I think that we got great result, great aesthetic. Just look at this because it is for the later. You see that something here happened. So this is when we start. I mean, when Stipe start. This is 1 year after when the orthotherapy was finished, and this is 3 years, 5 years, and 7 years. Now she came once a year for cleaning, and I think for checking. And here you see that those tooth, this one was lost 5 years after the treatment. So between 5 and 7 years, she lost this one tooth. So my diagnosis here is periodontitis. My diagnosis here is periodontitis. But you can see that this is 7 years to look at the same patient. We see here some black triangles. We see that the bone is not rapidly, but slowly progress. Or is it just aging of the patient? Yes. But I think that this is the best treatment option for this patient. Much better than, I don't know, bridges, implants, or anything else. The second patient is also, well, old. And here...
a week ago
yes,
he was
at
at clinic.
Yeah. This is the fistula, this is abscess, perio. This is how it looks. And I was thinking, well, Stipe, do it again. No problem. I'm not talking here
And
about...
I called my friend Harry Potter to help me.
I'm not talking about the intrusion of the tooth. You know that this is, for you, this is disaster. And I can really imagine that there are many things that can really go wrong with it. And we didn't have such an easy thing with this patient because once he had, I think, abscess again, and we were thinking, what are we going to do? We just cleaned it and gave him antibiotics, and everything went smoothly. This is the before treatment, so see where is the bone, and this is definitely, I would say, extraction case. We should extract this tooth, but we say, well, let's try and do something. And if you see, this patient has here fixed prosthetic work, so he can easily replace it, and he knows how he got the experience with bridges. But this is the end, and he's very satisfied with the result. And this, excuse me, and this is at the beginning, 1 year, 3 and 4. 4 years after the treatment, everything is quite okay.
Also aging. There's
Also
a black
aging.
triangle,
Yes, yes.
vertical loss of the bone. So
this patient is little younger, and this is after initial periotherapy. So I'm very proud of myself, because look at this. This is the peel of orange. Okay, so this is
healthy,
periodontal health. But you can imagine the appearance of these patients. You can imagine trouble that he has doing his everyday toothbrushing and everything. And I refer him to orthodontics and say, well, I think that there is something that can be done. This is from the view from the. So my diagnosis is here a mess. I don't know what is it. It's a mess, complete mess. And this is after, at the end of the therapy. It was only done in the upper jaw because no money, and this was just kako kažete ubrušavanje, kako se to na engleski kaže?
Selective grinding.
So, yes, grinding to make occlusion as good as it can. Of course, this is not good because this is not stable long term. But well, we are waiting to have more money or something like that. But I think that this is a quite good result if we see where were we when we started. And of course, the oral hygiene and the stability of those tooth is much better than.
Pardon, kako sam se tu podigla how did you elevate the bite so that you can put the teeth in the right order?
There were probably, so I was not the orthodontist, but probably there were some bite razors, so bite ramps in lateral segments in order to facilitate the correction of a cross bite, reverse overjet.
Yeah, at the start of the treatment he had lateral teeth on the lower left side, but at the end there are...
No,
yeah.
There are not.
There are...
There is a premolar there, so probably on premolar,
okay.
And also on the other side, maybe on some molar, whatever.
Sometimes.
Yeah.
Whatever, put it in.
Yeah. Maybe there was a plate that he had, some Schwarz plate in the lower jaw. I don't know.
Marco was the case that I thought that orthodontics will send me to hell. This is and this is the this is to show you how he has very strong lips and muscles, and it's impossible to do the proper cleaning here and to proper photograph here. And the thing is that this is the scar of her lower incisors, so it is always trouble. And I said, well, go if orthodontics can do something. I cannot do anything better than this. And this is the situation after. But the orthodontics told me that because of his very he's always she's having trouble with the retention here. So always is every month he has to come to split those teeth. And Ivor is my favorite patient because I was very involved in this periotherapy, orthotherapy, and prosthetic therapy. Of course, this is the picture after the initial therapy, but I got called from my colleague and she said, well, he is good with the one dental technician and she will do his job for free. He's my friend, I will do my job for free. But just tell me what tooth to extract and to do the bridge. And I said, okay, initially we have to extract everything from 4 to 4. And she said, I cannot do bridge here. I said, okay, I don't know. And then I said, well, let's try to do first initial therapy with antibiotics. And this is the thing that completely changed the mind of that patient because before therapy he was, I don't know, sex, drugs, and rock and roll. He was a heavy smoker, didn't care much of oral hygiene, and these are his pictures, so you see. These pictures are for me very peculiar because here you see very healthy gingiva, but it is because of the good therapy and the good oral hygiene that he started to follow. He has rituals for 20 minutes in the morning and 20 minutes in the night, brushing, then flossing, then cold press oil and everything. So he became obsessed with his hygiene, but that was good for us to do this kind of treatment. And then he went on orthotherapy. So this is the beginning of the orthotherapy, and this is the end of the orthotherapy. This is how it looked after the therapy, and this is how it looks now. The thing with this therapy, and I can call it a success, is that we lost 2 teeth. This one and this one. So this one is missing and this one is missing. And this orthodontic procedure was also kind of my idea to put all together the retention and the tooth that is missing. I would say that it is very brave for me to show you this picture and say that this is a success therapy when we lost 2 during the orthotherapy, but those tooth were lost long before, I would say. And I would also say that this kind of treatment with the prosthodontic is very minimally invasive, and I would say quite good. It is not perfect aesthetic, of course. We cannot have soft tissue here, but I think that it is quite okay. Of course, the patient is very satisfied with this. He is the one who is calling me for recalls. Every 4 months I clean him, and he's the one who is now taking care of everything. Of course, during the treatment there were some, I think, yes, this is the before and after. There was an endo treatment of this too. There were lots of, I would say, things happened during the treatment, but finally I think that this is quite good result. So these are cases I wanted to show you. Now I don't know about questions, about comments. Please feel free to read.
I have to go now because I have some other meeting. Really? So Vishnya will stay and they will try to resolve the whole problem and issues.
So it's Vishnya help.
Are there any questions?
Just one. Do you think that in Mia's case you would gain something by segmental arches if you extract?
Yeah, I would go with segmental arches. Yeah, but also so we have to extract first.
Exactly.
Then with segmental arches try to control the position of incisor, maybe to include first the canine and to move it back, then to lateral. Yeah. But at the end, she will have a lot of recessions. She will have recessions on all anterior teeth, even on canines.
Yes.
She will
That's
have
her starting
recession with or
point, so-
without orthotherapy.
So because at the start she didn't have the bone. So when you don't have a bone, you will have recession eventually.
Yes.
Maybe not at the age of 20, but at the age of 50, you will have a recession.
Why do you think that there is no something that's so obvious that there's no significant connection between lower incisor position and gingival recession in this systematic review? Is it a problem that they are done in too short period of retention, or?
Yes. There are not enough studies. And there are differently study designed so that they cannot do any, combine them or do meta-analysis. I was kind of surprised. First when I started reading, I thought, oh, I will find plenty of, it will be easy. But then I saw, no, it's not like that. And I myself see, I don't want to say every day, but every week maybe we see 1 or 2 patients with the recession after ortho treatment. So it is an issue, clinical issue, but as a scientist, as someone who works in universal clinic, I would like to tell you the scientific evidence, and I didn't find that. Of course, there are some studies that say yes, it is, but there are some that say no, it doesn't matter. So really, it is something that also surprised me.
And then if one day in the future posta vidimo, ovdje nas možda bi bilo dobro raditi CBC te prednjeg segmenta
Always.
mandibule gotovo uvijek kad želimo manevrirati.
Da.
do
And
njega
how
sredine.
reliable it
Yes,
is.
and how reliable it is, but the problem with CBCT, I talked to my colleagues from EMA, and before CBCT, they got some hopeless case, and they say, okay, let's try. And they try, sometimes they succeeded, sometimes they didn't. Now they say, do the CBCT. And they say, extract the tooth. So they, because CBCT show you your limitations, I would say. And then maybe we have this great diagnostic tool that we can use before and then be aware of all the risk or everything that there is. Because, I don't know, those from Endo say that before CBCT they will go and do treat every tooth. And now they say that there's no point because we cannot succeed. So I don't know whether it's good or bad, but I think that it's good. Because I don't think that the treatment of one tooth and then it will last for 2 years and you have extracted, I don't think that's a good therapy at the first place. So the conclusions will be, the first one, of course, that more studies are needed, but that's a stupid conclusion. The second thing is that there are some clinical recommendations that I gave you, and you will have this presentation so you will be able to find them and maybe try to minimize the risk of gingival recession. And about those 5 cases that I show you, what I would kind of like to tell you, as I'm kind of old clinician and you are young, try to treat the patient and not deny ideal, because what's the use of ideally positioned tooth if they're outside of the bone, outside of the mouth, outside of that patient, and try to, but with years it will come, don't worry, try to skip some rules and make it ideal for this patient, this one that you treat. Hvala na pažnju.
Thank you very much.
I have one question.
Yes.
There are some trends, at least in our country, for plasma-associated or plasma-assisted gingival recovery, periodontal pockets recovery. As a periodontist, what do you think about it? Have you had experience with that? Is it long-term, short-term?
We have plasma, not in our department, but in our oral disease department, oral medicine department. and we don't use it as much as we could because it proved to have some beneficial effects on healing, but we only use it when something went terribly wrong. Then we say, well, let's try to facilitate the healing with this. But I think that it would be wise to use it if you have it, of course.
Because so far my experience is that it heals for about 4 to 5 months. It starts, and at the moment when it starts to promise that it's gonna be okay, then it's like, oh, it's not okay.
No, we don't have that kind of experience because we don't have much experience because we only, I said, use it when something went quite wrong. Then we try to do, but not in the everyday practice with all the cases. Što kažeš? O, tu.
Aha, evo,
Tu sam stavio, da, tu sam stavio.
I onda još moramo jednu onaj group photo for Facebook. It's not on Facebook, it didn't have it.
Of course.
Možemo vaditi. Hvala. Ja jedino ono što sam zamišljala sve do ovoga periosta i onda ona 3 sloja periosta
Ne, jer to je to dok sam pripremao predavanje što je meni. I onda sam rekao, pa čekaj koliko